Welcome to another episode of Surgery from Snazzy Surgeon. Today we're undertaking a focused deep dive into laparoscopic inguinal hernia repair, specifically comparing the transabdominal preperitoneal or TAPP and the totally extraperitoneal or TEP approaches. Our aim is to really extract the critical anatomical considerations, those technical nuances that can, make or break these procedures, and the potential pitfalls we all need to be aware of in practice.
Absolutely. Both TAPP and TEP are, well, they're mainstays now, aren't they? Offering patients real benefits. But having that nuanced understanding of their differences and let's say, the subtle anatomical landscape is just essential for good outcomes and, importantly, minimizing complications.
Okay, so let's start right there with the crux of it. TAPP versus TEPI. The primary divergence, it's really about the initial access, isn't it? One goes into the peritoneum, the other tries to stay outside.
Precisely. With TAPP, our first step is actually entering the abdominal cavity. That allows us to create a peritoneal flap and then get down to the preperitoneal space where the defect is. The crucial step later then becomes securely closing that peritoneal flap back over the mesh.
Right, and that's where TPA takes a different path. As the name implies, totally extraperitoneal. The whole repair happens within the preperitoneal space, ideally without ever breaching the peritoneum. The immediate advantage that springs to mind is you don't need to close the peritoneum over the mesh.
That's a key distinction.
Yeah.
With potential implications. By staying extraperitoneal, you theoretically cut down the risk of complications tied directly to peritoneal entry and closure. Things like adhesions, which could rarely lead to bowel obstruction. Now, the incidence is low even with TAPP, but it's, a theoretical plus for TP.
So, okay, regardless of which path we take, TAPP or TP, any surgeon doing these needs an almost instinctive grasp of that preperitoneal anatomy. It's the terrain we're working on.
Without question, a thorough, really unwavering recognition of that anatomy is non-negotiable. It's about safety and efficacy. Because within that space, it's relatively confined, you've got critical landmarks and, well, danger zones that demand respect.
Let's pinpoint some of those. The triangle of Dune comes up immediately. Borders being the vas deferens medially, spermatic vessels laterally, and the iliac vessels below. Dissection there, if you get too aggressive, carries a big risk of vascular injury.
Indeed. You approach dissection in the triangle of Dome very cautiously, or, ideally, you avoid it entirely. And just superior and lateral to that, you've got the triangle of pain that's bordered by the iliopubic tract inferiorly, the gonadal vessels laterally, and the lateral edge of the vas medially. Fixing tacks there, that's a well-known cause of postoperative neuralgia.
And just to hammer that home, the quadrangle of pain and doom, the name says it all, really.
Yeah.
Tacking there is strongly discouraged. Combined risks.
Exactly. And adding to that anatomical map, we have to consider the corona mortis, the crown of death. This is a potential and sometimes significant vascular connection between the internal iliac, specifically the obturator branch, and the external iliac, or its inferior epigastric branch. Injury here can cause really significant unexpected bleeding. So vigilance during that lateral dissection is key.
It's those vascular variations, often unpredictable, that can turn a seemingly straightforward case into something much more complex. Now, shifting focus a bit, specifically to TEP, the transition zone at the arcuate line of Douglas becomes particularly important, doesn't it?
Absolutely. Understanding where that posterior rectus sheath essentially disappears, leaving just transversalis fascia, is critical for getting the right entry and dissection plane in TET. If your initial dissection in TEP is too high, above the arcuate line, you might end up in the retrorectus space. That's not where you want to be.
Okay. And within this preperitoneal area, we're navigating through key potential spaces, right?
Right.
The space of retzius anteriorly, space of pulchros posteriorly. Knowing these planes is essential for both techniques.
Yes, these spaces offer relatively avascular planes. They help with the dissection, allow for good mesh deployment. In TEP, the initial entry often targets retzius, and then the balloon dissection and instruments let you extend back into Bogros. That gives you the exposure needed to cover the whole myopectineal orifice of Fouchot.
Right. Okay, let's move to clinical decisions. What points us towards laparoscopic repair in general? Recurrent hernias, bilateral hernias, those seem like strong indications, regardless of TPP or TEP.
That's pretty well established, yeah. The laparoscopic approach gives distinct advantages there. You're often dissecting through fresh tissue planes, potentially giving a stronger, maybe less painful repair.
But the role in primary hernias, that's still debated somewhat in the community, isn't it? It's not the automatic first choice everywhere based on current evidence and opinions.
Precisely. While laparoscopy offers those clear early benefits, less pain, quicker recovery, sometimes the long-term outcomes and cost-effectiveness compared to open repair for primary hernias are still being looked at closely in studies. Surgeon experience, patient factors, they weigh heavily too.
On the flip side, we need clear contraindications. Patients unfit for general anesthesia, obviously, are out. GA with an endotracheal tube gives the muscle relaxation and airway control needed.
Agreed. Good muscle relaxation is absolutely paramount for visualization and safe dissection down there.
And the hernia itself can dictate things. Strangulated or incarcerated hernias often mean an open approach, right? To directly assess bowel viability, maybe do a resection. Trying a laproduction there is risky.
That's a critical point, yeah. The controlled setting of open surgery allows safer handling of potentially compromised bowel. You can see what you're dealing with directly.
Interestingly, previous retropubic open prostate surgery is often seen as a relative contraindication, especially for TEP. The scarring in that preperitoneal space can make dissection really tough.
The fibrosis, the altered planes.
Mhm.
It significantly bumps up the risk of tearing the peritoneum and just makes that extraperitoneal dissection very unpredictable, potentially hazardous.
And finally, any active infection or inflammation nearby. That would generally rule out an elective lap repair because of the risk of mesh infection.
Correct. In those cases, you deal with the infection first. Hernia repair might need to be delayed or maybe done open without mesh in some situations.
Okay, so let's say lap repair is appropriate. Anesthesia and prep are fundamental. We mentioned general anesthesia with ETT is standard.
Provides the optimal conditions. Controlled, safe.
And informed consent needs to be meticulous. A frank discussion about all the risks. Recurrence can happen due to technical faults, maybe too small a mesh.
Crucial to emphasize that even with perfect technique, there's still a small recurrence risk. We also need to cover bleeding, especially from that triangle of doom or the corona mortis.
Neuropathic pain, neuralgia, potential injury to the genitofemoral or lateral femoral cutaneous nerves. That's another important one to discuss.
Yeah.
And the rare but obviously serious possibility of injury to the vas deferens, particularly in younger men.
Bladder injury, though uncommon, is a risk, especially with prior pelvic surgery or large direct hernias pushing down low. And bowel obstruction, while more linked to open surgery, can happen with TAPP due to adhesions involving the mesh. Plus, mesh infections, seroma, hematoma, hydrocele all need mentioning.
Practical pre-op steps then. Get that comprehensive consent, including possibility of converting to open, maybe needing to fix the other side if you find an unexpected hernia, and marking the correct side. Basic, but essential.
Absolutely. And just before anesthesia, ensuring the bladder is empty. Simple step, minimizes risk of bladder injury. Patient positioning, supine, slight Trendelenburg, head down tilt, helps keep the bowel out of the way. Monitor at the foot of the bed for best ergonomics.
And the surgeon typically stands opposite the hernia side, right, for optimal instrument handling and view. Arms tucked securely at the sides to give the team space.
Okay, patient positioned under anesthesia. Next up, creating the pneumoperitoneum. Either closed Veris needle technique or an open Hassen's cannula approach. Then connect the S.02 auto-insufflator to maintain pressure, usually around 12-15 millimeter G initially, maybe lower it later.
And strategic port placement. And this differs a bit between TAPP and TEP, reflecting those different approaches. For TAP, standard setup is usually a 10 millimeter port at the umbilicus for the camera, then two 5 millimeter ports at the lateral border of the rectus muscle, one on each side.
And for TEP, the initial access is often that small open infraumbilical cut. You put a 10 millimeter port directly in, often a Hassan-type blunt port. After that, two more 5 millimeter trocars, typically placed midline between the umbilicus and the pubis, usually under direct vision. Sometimes a 10 millimeter might be used instead of a 5 millimeter, depending on preference.
Right. Now let's walk through the TAP procedure itself. Key steps. The first critical move is incising the peritoneum. Usually from the medial umbilical ligament out towards the acis, about 2 centimeters above the internal ring.
Then you elevate that peritoneal flap, which includes the hernia sac, carefully off the structures underneath, dissecting inferiorly towards the iliacs, superiorly towards the abdominal wall muscles. For those really big indirect scrotal hernias, sometimes you divide the distal sac, leave it in the scrotum, avoids extensive, potentially tricky dissection around the cord.
Once the flap and sac are mobilized, you reduce the contents omentum, maybe bowel back into the abdomen, then the crucial dissection of the cord structures and vas, making sure they're fully freed from the sac.
Exactly. And this dissection continues into the preperitoneal space. Systematic identification of landmarks is paramount here. You need to clearly see Cooper's ligament, the iliapubic tract, internal ring, Vas, gonadal vessels, external iliac vessels, and watch out for nerves, especially the femoral branch of the genitofemoral.
Sometimes, for complex cases, large indirects, you might use parietalization of the cord, the stop-EAPA technique. Basically, circumferential blunt dissection of the sac off the cord and vas. Ensures full mobilization, good mesh coverage.
Once a space is developed, sac dealt with, then comes mesh placement and fixation. A rolled-up mesh, usually 15 by 10 centimeter polypro, goes in through the umbilical port. Critical that it extends medially past the median umbilical ligament and covers all 3 potential hernia sites in Frouchot's orifice.
Fixation. Tacks, absorbable or not, fibrin glued, sutures. Depends on preference and the situation.
Yeah.
Laterally, you must stay above the iliopubic tract with any tacks. Avoid nerve entrapment. Medially, tacks can go into the rectus muscle and onto Cooper's ligament.
With the mesh positioned, the last key step for TAPP is closing that peritoneal flap. Usually drop the pressure to around 9 millimillar Hg to make it easier. Carefully bring the edges back together over the mesh, using maybe a running absorbable suture or interrupted absorbable tacks. Need good overlap to keep the mesh away from the bowel. Then, ports out, close the 10 millimeter umbilical port fascia with interrupted stitches, skin closed with single interrupted stitches.
Okay, now let's switch gears to the TTP procedure intricacies. The initial entry into the properitoneal space is different, usually via a small open approach, vertical infraumbilical skin cut, maybe 1.5 to 2 centimeters.
Yes. Dissect subcutaneous tissue. Use retractors to expose the anterior rectus sheath on the hernia side. Incise the sheath under vision, place stay sutures. Then separate the rectus muscle bluntly with retractors to see the posterior rectus sheath underneath.
And here's the key difference from TFCP. Instead of cutting the posterior sheath, in TEP, you dissect downwards and a bit laterally, maybe 30 degrees towards the pubis, staying below the arcuate line. This blunt dissection, often with a finger or a dissector, gets you into that avascular properitoneal space.
Right. Once you're in, often a properitoneal balloon dissector helps create the working space. Inflate it under direct vision with a 0-degree scope. Important here to make sure the inferior epigastric vessels stay up with the rectus muscle, avoid injuring them.
After creating the space, a Hasson port, usually 10 millimeter blunt tip, goes through that infraumbilical incision, guided by a 30-degree scope. Then the 2 extra 5 millimeter trocars go in midline between umbilicus and pubis, again under vision, setting up your working triangle.
And throughout TEP, it's wise to keep the pressure a bit lower, maybe below 9 millimole Hg. Reduces the chance of accidentally tearing the peritoneum. If a tear does happen, you need to spot it and close it carefully. Endoloop or a 5 millimeter clip usually does the trick.
Like TAPP, meticulous landmark ID is essential in TEP. Cubic bone, Cooper's ligament, the lighthouse sign, because they look white, are key orientation points. Also critical, avoid dissecting below the external iliac veins. Prevent vascular issues. Ultimately, the view in a good TEP should look pretty similar to TAPP.
Managing the hernia sac in TEP follows similar principles. Small, indirect sacs, often you can just reduce them completely. Larger ones, reduce the contents, transect the sac, leave the distal end open, close the proximal end with an endoloop or clip to prevent seroma.
Finally, mesh placement and fixation in TEP. Introduce the rolled mesh, carefully spread it out to cover all 3 potential hernia spots in the myopectoneal orifice. Fixation again with tacks or sutures, paying that same critical attention to avoiding the triangle of doom and triangle of pain. Prevent nerve or vessel injury.
And regardless of TPP or TEP, the post-op care principles are pretty consistent, aren't they? Many are day case procedures now. Patients go home same day or next morning, usually just needing mild oral painkillers.
Early mobilization is key. Get them moving as soon as they're recovered from anesthesia. Prophylactic 5E antibiotics intra-op are common practice to reduce infection risk, including mesh infection.
Yeah, and time off work after an uncomplicated lap repair, TAPP or TT, is usually short, typically around 3 to 6 days, then a gradual increase in activity as they tolerate it.
So we've taken a pretty focused look at both TAPP and TTP for laparoscopic inguinal hernia repair. We've highlighted those critical anatomical points and the specific steps for each. Understanding these nuances really is paramount for minimizing complications and optimizing patient outcomes in our day-to-day practice.
Indeed. The subtle but significant differences in technique, plus the absolute need for that detailed anatomical awareness in both approaches, really underscores the importance of meticulous surgical execution for successful, durable hernia repairs.
Thank you for listening to our podcast. See you in the next episode.